All right, awesome. We are live, and I'll just start off by introducing the talk today. We're talking about drug use and harm reduction in an urban environment. My name is Libby Averick. I'm the digital communications specialist, and today I have Lee Rusch, director of the Westside Heroin Opioid Task Force, and Carolyn Bloom, harm reduction program manager for AFC and Center for Housing and Health.
Okay, thank you, Livy. I'm going to start out. Hi, again, my name is Carolyn Bloom. I use she, her, hers pronouns, and I manage a program for the AIDS Foundation and Center for Housing and Health called Connection to Harm Reduction. We work with folks living in permanent supportive housing and support those folks who are using drugs in a chronic fashion through a harm reduction approach. So today, Lee and I are just going to give a very kind of high-level overview of harm reduction and our experiences working in harm reduction in an urban environment, namely Chicago. So our learning objectives for today are going to be talking about the overdose crisis that we're currently in. I'm sure if you're participating in this webinar, you're well aware of the dire consequences and circumstances that we're in as a result of a very contaminated drug supply that we have right now. So we'll just briefly look at those stats just to remind everybody or inform everybody about where we're at. We'll talk about some of the drug contaminants that are being found in the drug supply today. And then Lee's going to talk about his work with the Westside Heroin Opioid Task Force. And then we'll share some resources with you and then finally open it up to questions and share our contact information. So when we look at the overdose crisis, I really like to refer to it as an overdose crisis rather than an opioid crisis, because it's really not about opioids only. Most people who use substances in a kind of chronic or chaotic way use more than one substance. And I don't want to focus so much on an opioid crisis, because what happens with that is a lot of people who use opioids for chronic pain are lumped into that group, and those are the people that are left out and unable to attain the medication that they need. So this is really about an overdose crisis. And I also want to emphasize that not everyone who uses substances does so in a way that would be a substance use disorder or would be considered chaotic or chronic. Most people who use substances, the vast majority of people, and that goes for all substances, use so in a way that it's recreational use and there are no negative consequences that affect them fulfilling the responsibilities of their life. So in the US, the CDC looks at these stats in kind of a rolling year. So this is the latest stat that looks at October 2021 through October 2022. And you can see the predicted number of deaths is well above 107,000. And you can see by this visual that that number of overdose deaths just keeps increasing. And then when we look specifically at Illinois deaths are up at almost 4,000 deaths just in Illinois. All of these deaths are preventable. Nobody should be dying alone of an overdose. And it's really just a tragic consequence of the prohibition and criminalization we have of drugs. So when we look at the overdose crisis, a lot of public health officials will look at it in waves. So initially they talked about the 3 waves of the overdose crisis. And really now today, we're talking about a 4th wave. So the initial first wave really started out with the proliferation of prescription medication. Everybody heard about Big Pharma in the news, overprescribing opioids to people. And then the government, the DEA came down on those doctors in the early 2000s, you can see there around 2007, and really cut people off from their prescription medication very abruptly. Doctors became very worried about being identified and investigated for overprescribing, and still to this day, a lot of doctors are very reticent to prescribe to chronic pain patients. And so what happened with that is then people went to the street supply. And so then we had the proliferation of heroin where people couldn't access their medication. So they found that pain medication in the heroin supply, which with the prohibition and criminalization of heroin, then we got to where we are today with fentanyl. So fentanyl is really the dominant opioid in the heroin supply. Most users who use heroin know that fentanyl is a given. It's largely replaced all heroin. But it's also getting into the stimulant supply. It's certainly not as prevalent as it is with the opioid supply, but it also is in the stimulant supply, and stimulant use is on the rise as well. The thing with stimulant use is that a lot of those deaths are heart-related events, so it's also hard to quantify them as stimulant-related. But like I said, a lot of folks combine a stimulant, and when I talk about stimulants, for example, are methamphetamine and cocaine. Those are commonly used stimulants. And so now we're looking at a rise in stimulant use, and that is what we're now referring to as the fourth wave of the overdose crisis. And this visual really just goes to remind folks that this isn't right now, these deaths are not about prescription medications. As you can see by this like hyphenated blue line there at the top, the volume of prescription meds that are being prescribed by doctors has been plummeting for years. So I'm not going to discount that there aren't overdose deaths from prescription meds, but that is not what's driving the overdose deaths at this time. As you can see by the red line, that is deaths from opioid-involved overdose deaths, and that is way up. So this is not about prescription medication, but is definitely impacting those patients with chronic pain who need those prescription meds. And this is just another visual that shows, you know, about 75% of the overdose deaths that are happening are being driven by fentanyl in the drug supply. So this is a wonderful website that, I mean, I guess you can call it wonderful, but it has a lot of good data. You can see the location there at the bottom. It's called drugsdata.org. You can pull this up and you can look at information in specific cities. So you can pull up Chicago and you can see what's being tested in the Chicago market as far as people testing their drugs. So this just highlights 3 samples of what's being sold as dope or heroin/fentanyl, and you can see everything that's in these, you know, what used to be someone maybe back in the day thinking they're just getting dope. So they're getting a lot of other things in there as well. It's kind of a garbage can. And so one thing that I want to highlight that I'm going to talk about in a minute here is xylazine. So xylazine, if you haven't heard of it already, you will be hearing about it. Xylazine is also a depressant, but it is not an opioid. So xylazine is actually an animal tranquilizer that's used for large animals by veterinarians. And it is now getting into the drug supply. It started out in Puerto Rico, moved its way to the eastern half of the United States, and has now really been found, I think, across the whole US. It's not FDA approved for human consumption, but it is commonly found now, typically in conjunction with opioids. I'm not saying it's never been found in stimulants, but it's much more rare. It tends to go along with fentanyl. And in fact, just this week, the Biden administration classified fentanyl combined with xylazine as an emerging threat. And that is actually a term that has to be, there's criteria for something to be deemed an emerging threat, which means that the government says that in the next 90 days, they're going to be looking at what they can do about this. But we also know that if we head towards criminalization, just like we have with fentanyl and everything else, that there are dire consequences with something that is actually needing a public health approach. So this all goes back to what we call the iron law of prohibition. When you prohibit something, this is what happens. If you have any history knowledge of when alcohol was prohibited back in, I think it was in the 1920s until like 1930, and people were making moonshine because they prohibited alcohol. People died of that poisoning from that alcohol. This is very similar. That's what's happening. So that is what has brought us fentanyl into our drug supply. And you can see there that what happens when we prohibit and criminalize is that different things are created and made that are cheaper and easier to get into the country. So I didn't provide a graphic for this, but fentanyl is brought in typically through Mexico. Typically, what most people don't understand is it's brought in through legal ports of entry. If you're interested in a graphic that supports that, I would be happy to provide that, but it typically comes in through legal ports of entry and typically comes in via US citizens. So closing closing the borders, as everyone likes to talk about, is not going to change anything. And so as fentanyl is more powerful than heroin, it means, as it says here, that you have to smuggle in much less fentanyl compared to how much you would have to smuggle in for heroin. So 50 pounds of heroin would equal only smuggling in 1 pound of fentanyl. So it's much easier. And then I think I have to mention, and what I think it's important for people to understand is fentanyl has been used for a long time for medical purposes. It's used as a pain reliever, it's used in anesthesia, and it's used very safely in hospitals and has been for years and years. But the illicit supply that's on the street is much more dangerous. It does not necessarily mean that someone is going to die should they use fentanyl, but if they've never had an opioid in their system, they are going to be at a higher risk of overdose. But there are people who seek out fentanyl and they have a tolerance for fentanyl. And so they use it very regularly. But what happens is with the criminalization and the panic is that it is a very real thing and it is a very dangerous thing. But with law enforcement and the media, they sometimes will stoke that panic about touching fentanyl or fentanyl being airborne, and law enforcement officers, if you haven't seen law enforcement officers doing searches and having hazmat suits on and worrying about coming in contact with fentanyl. And what happens with all of this kind of panic is that the criminalization is increased, more money is sent to law enforcement, and it just equals prohibition, criminalization, and everything that comes along with that. And so it also stokes fear in that if someone sees someone who's overdosed and suspects that they may have used fentanyl or assumes that they have, they probably aren't going to step in and help those people because they're worried about coming into contact with fentanyl. So fentanyl is not going to cause someone to overdose should they come into contact with it. So when these law enforcement officers are searching cars and then all of a sudden they have what is more likely to be an anxiety or panic attack and need to be Narcaned, we don't hear about the results once that person goes to the hospital and there's been, no opioid in their system, and they're really not showing any of the symptoms of opioid toxicity. They're showing symptoms of a panic attack. And so a fact is that fentanyl has to enter your body for it to affect you. So being in a room is not going to make you overdose. Touching fentanyl is not going to make you overdose. Trying to help someone who has overdosed with a fentanyl involved overdose is not going to cause you to overdose. Simply being in the same room is not going to cause an overdose. I even saw a story about fentanyl fumes on a bus. I'm not even sure what a fentanyl fume is, but it's not legit. So xylazine, which is an emerging threat with the drug supply, has been in the news. The FDA finally released something acknowledging that xylazine was a real threat. I recently read something that it is not necessarily being diverted from veterinarian offices, but it's being bought illegally on the dark web in many different forms. You cannot see it in your drugs. It also, for people who are using via injection, is causing horrible skin wounds and like a necrosis of the skin. I refrain from showing any of those pictures here, but it does real damage to people's skin at the injection site and even at places on their body that were not involved directly in the injection. There are testing strips for xylazine that are being developed that are very new by the same company that has fentanyl test strips. The xylazine test strips are available in a limited purchase, but not generally to the general public at this time. And so there's just a highlight of the alert that the FDA finally issued in November, but you are going to be hearing more and more about xylazine, very similar to how you started to hear more about fentanyl in the drug supply. So now I'm going to turn it over to Lee to talk about the West Side Heroin Opioid Task Force.
Well, thank you, Carolyn. And thank you, everybody, for having me today. And I just want to say it's been a real pleasure to work with Carolyn over the last 3 years or so. I always kid her because she's one of the first people ready to get on a Zoom when we have one. But as you can tell by her presentation, she knows her stuff. And I learned a lot today, too, about how to present it. So thank you, Carolyn, for your continued involvement in the task force.
Thanks, Lee.
Great. So let's go to the next slide. I'm one of the co-founders of Prevention Partnership that was founded back in June of 1987 as a not-for-profit. My colleague, Luther Sias, who is the director of outreach, was also a co-founder, and Al Orsello, who still serves as the executive director, was one of the co-founders, along with then Alderman Danny Davis. Of course, now he's Congressman Danny Davis. And so we had a great folks working, beginning this and also continuing through this process. We were, word prevention is in there because we were primarily a community-based prevention organization. You can see our mission here. And one of the key pieces of our work was a community systems approach, meaning that it isn't just the people who are specialists in prevention, but we really want to engage all sectors of the community to identify what's currently going on, what we really want to do, creating a blue sky or a preferred community, and then building action plans to get there. We believe that everybody in the community needs to be a part of this. And that's the way what we brought along into what we're doing with the Heroin Opioid Task Force. And those are some of the programs that Prevention Partnership has going on. We've kind of, the outreach, the task force has kind of created its own little space within Prevention Partnership, but we do a lot of interaction with them. If you can go to the next slide. The task force was convened in 2016 by Rep. LaShawn K. Ford and others. I believe one of the hospitals was the coordinating agency at the time. It brings together community-based agencies, governmental entities, healthcare providers, businesses. As you can see, it's kind of that community systems approach. We're especially interested in including people with lived experience and even the people who use drugs. And the real primary piece was to deal with the opioid overdoses and the resultant deaths on Chicago's West Side community. It has been pretty much over the years, and currently the overdose deaths in Chicago, about 35% of them come from the West Side of Chicago. And when I talk about the West Side, the areas we serve are Austin, East and West Garfield, North Lawndale, and Humboldt Park. And so that's traditionally been, I guess you want to have a tradition of this, but kind of historically been, about 35% of the overdoses and also the overdose deaths. This year, though, the amount of overdoses or EMS calls for overdoses in 2022 was down slightly from 2021. And we're hoping that we'll see that same piece in the deaths, even though in Chicago at large, there has been a slight increase in the EMS calls for overdoses. So we believe we're making some headway. We're moving along, okay. Prevention Partnership was asked to take over convene the task force in July of 2019. So we're coming up on our 4th year of being the coordinating organization for this. And it's been a real amazing ride with partners like AIDS Foundation and all those other community sectors involved. We have monthly meetings virtual, and we do have special focus work groups as well. Right now, we have fentanyl work group that's really looking at all the other adulterants in the drug supply, including xylazine. We have a housing work group that's really focusing on how we get people we're meeting on the street into housing without long delays. We also have a CTA/Narcan work group that really came out of a number of people's concerns about the number of overdoses that happen on the trains and the buses and/or in the platforms. One of the people who was really strong in this work group was lost her son about a year ago on the Rosemount platform. He was alive when people found him, but nobody had Narcan, and he passed away before the EMS folks got there. So this is really near and dear to her heart, and we really are trying to make headway to get past whatever kind of barriers there might be for either CTA employees to be trained and able to give Narcan, and/or have that available on the trains. And we also have a legislative task force we'll talk about a little bit later. We have informational e-blasts, and if you'd like to be a part of these e-blasts, you could probably leave your information in the chat for Libby to pick up. We're on social media. We got off of Twitter. That was, I guess, my choice, but I don't think that we did get much play on that, and it's kind of a mess right now anyway. So the other piece we do annually, an International Overdose Awareness Day event. That's always on August 31st. And that's of course, that's international. There are other events happening, but we've been fortunate to be able to set up at Pulaski and Jackson every year and get, a number of community people, a number of our providers together. And it's just a nice, great event. And please, if you do sign up for getting information, follow that. Carolyn's been there for the last 3 years, and we hope the next year as well. And when we became the task force convener or coordinator, Rep Ford is our convener. Shortly after that, we were asked to take the key role in what is called the Community Engagement Project on overdose prevention sites. We're working with a evaluation component from the Advocates for Human Potential. And the whole piece was to work with the West Side community leaders, community members, people who use drugs, people in recovery, et cetera, to get their feelings, their understanding of what overdose prevention sites are and what they think about them. So we've done about 800 surveys with people. We've done 14 community focus groups with various community sectors to get their ideas about this. That's a whole nother presentation, but primarily what we see is that about 80% of the folks who we interview across whatever group we're talking about believe that there is something needs to be done, and that they'd be willing to really consider overdose prevention sites. Some of the concerns is what probably are put up anytime somebody talks about a overdose prevention site or any kind of program that might be people who use drugs, is that they don't want it to be what is called a honeypot, where both dealers could be hanging around outside to be able to sell, and/or police would use that to be a way to kind of grab people and arrest them. They're also concerned about just the community at large and some of those concerns. And on the West Side, one of the main concerns when any new program comes in there, are people from the West Side going to be employed? How long is this going to be? Is this just going to be a pilot and it's going to move on to some other community? I think the sense of abandonment and being left out of projects has been something that should be and always kind of is there when we talk to people on the West Side or any community that's been underserved chronically for many, many years. And we also have, and this last piece here it's not the least, because it really the street outreach piece really put real meat and potatoes onto our efforts. It got us out of just kind of sitting around and talking about a problem and really began to ground ourselves in the realities of what's going on the West Side. Next slide, please. So beginning in September of 2019, we started an outreach. Our outreach director, lives in the West Side community, lives around Superior, and I shouldn't even say that close, but around our office, around Austin and Lake Street. And one of the first things he did is say, well, who's out there giving out Narcan or naloxone? And from his looking around and getting a sense of it, there were only maybe one or two organizations that actually were getting out into the community. None of them were like strolling the community and kind of walking around and being kind of face to face with the people who were using right out in the middle of the hotspots. So he pulled together some people he knew from his constellation who had experience. One of them actually had died and was brought back to life, with some impairment afterwards, but he brought them together. And when he went out with them, he started out sites where hotspots that Lou, driving by and living in that community, had never even seen. At that time, we were using heat maps, or we were given heat maps that were given to us by the state unintentional drug overdose response system. But those hotspots maps were about a year old or so, because they had to go through the whole kind of verification through coroner's office, et cetera. So really the team pretty much started going to places where they knew there was drug activity and began to do on-site Narcan training and distribution. So like you can see to date, they've given out about 12,000, or met with about 12,000 individuals and distributed about 24,000 doses of Narcan. This picture was taken in April of 2019. They began in September 2019, but took a break in March when the COVID outburst or outbreak started. And they said, hey, we got to get back out there. So you see them in their full hazmat suits and everything that they had, and they were ready to go back. They made a scene. That was people recognized them pretty much quickly after a few days out there. So that is not about fentanyl. That is about making sure that they were not either giving or receiving COVID. Nobody on that team has had COVID yet, so that's a pretty amazing situation. But their presence out there in the community really sparked a lot of our partners in the treatment side of things and the early intervention side of things to get out of their offices and join us. About a year into this process, we were joined by someone from another organization who came out and could not believe the scale of the problem out there on the street and how many people were either under the influence, homeless, and just out there really having a tough time. And he also was very impressed with the rapport that this outreach team, the members, had with people who use drugs, and the willingness of those folks to spend time learning about how to respond to an overdose, et cetera. So that has grown. I don't know what my next slide is. Okay. Yeah, well, let's talk about the strengths of the outreach effort. It's staffed by community residents. So people who are on that team basically wake up and go to sleep in the same neighborhood that they're servicing. People with lived experience. If it's not lived experience through having a opioid use disorder, a substance use disorder, it's about being comfortable being out on the street. We were initially trained by CRCC, Chicago Recovering Communities Coalition, and the excellent 3-hour training of trainers that Chicago Recovery Alliance was doing at that time. I know they suspended it during COVID. I was told by John Wording, their executive director, that it's back in play. And I think it's just wonderful. It's not just about how to respond to an overdose. It's really gives you a strong underpinning of the harm reduction practices that you can see that Carolyn was really steeped in herself, because her warnings on about going overboard on fentanyl and the whole issue of prohibition really is one of those principles in the practice within harm reduction. The other piece is that it's not on here, but we all, from the prevention partnership side, said, hey, look, if we're in a crisis, we have to step up our response. And so one of our pieces is we really want, if somebody reaches out to say, hey, can we be a part of this task force, or hey, something's going on over here, we'd like to get back to them within a day at the most, but hopefully immediately. We want to step up the cadence of our work out there, because we can't just kind of keep operating at our usual pace in recovery in the process of giving support to people. We need to really treat it as the crisis that it is. And I think that has really kind of sparked a lot more immediacy in our collaboration. And it also having that initial people coming out and kind of seeing what our rapport and seeing how the scale of what's going on there has really led to a warm handoff process that's out there. Meaning a warm handoff, meaning that if somebody's out there with us and said, hey, I'd really like to, get into treatment, or I really need to get into detox or medical stabilization, that we had phone numbers that we could write out there with us from one of the treatment programs within an hour or so. Now we have two mobile vans, one from COIP, Community Outreach Intervention Program from University of Illinois, Chicago, and Family Guidance Centers, who have vans where they can actually begin methadone or Suboxone induction right on the van. And we also have a number of other providers who can get people into treatment pretty much immediately. Because at a time when somebody's ready for treatment, we don't want to say, oh, here's a card, why don't you give them a call? And whether we really sparked this or not, we now have MAR Now that Family Guidance is kind of managing, or not kind of, but they're managing, where people can get referrals to medicine-assisted recovery pretty much within a 24-hour period. And at 24 hours a day. So we also really began to keep detailed records. Initially, we had a half sheet that we had on a clipboard because we wanted to find out who the person was, what their phone number was, where they lived, and some basic information about them. We had it on a half sheet so that we didn't have, everybody had their own special sheet, so nobody, wasn't just like we had a sign-up sheet so some people could see other people's names. Now we have about a 2-pager that generally people we're training out there will take the time and give us a lot of information. So we're learning about housing situations. We're learning about what drugs people are using, how they're using them, whether or not they have overdosed before, whether or not they have saved a life from reversing an overdose. And we probably hear about 80 people a month saying that they've saved a life. We were getting upwards about 50 to 60 people a month are getting referred to some form of follow-up treatment, whether it's on those vans or in some other piece. We're learning a lot about drug trends. And I should mention just parenthetically that the majority of people on the West Side who use opioids either snort or smoke. So when we talk about overdose prevention sites, we try to keep with that language of overdose prevention sites, because we don't want to get into talking about safe injection sites, which really mischaracterizes what's going on the West Side. And it's also a scarier sell, I think, and it really doesn't tell the story really about overdose prevention sites, which mean that they're much more varied, many more services that can come out of there than just having a space for somebody to inject drugs. But the open to collaboration for us as prevention partnership to really subsume our name in this whole thing, something to grow Prevention Partnership as an organization through this work. It was to grow the collaboration and to really highlight our partners through posting their information on social media, getting it out in our e-blasts, having meetings where each of the organizations report out on what they're doing, and just generally really taking the lead and subsuming that into hey, what's good for this community is good for our organization. We do daily debriefs. I'm the least popular guy because I told them that was my idea, but every day after our events, it's usually about 4 hours where our team is out there. They write up, answer the questions: what happened? Were you surprised? How many people did you see? Who was out there with us? What would we do differently next time? And that allows really self-correct as we go, and to find out new things that are happening. And now we've been to, I'd say, hundreds of street corners on the west side, and now our team is known. People come back to us, as well as COIP and other groups. The utilization of our work, I think, has really grown continuously. So we're training about 550 people a month and giving out twice as many doses of Narcan. We're giving out fentanyl test strips, PPE. We have clothes. We have a connection with a gentleman that goes by the name of Superhero. So we have food out there a few times a week. So it's continuing to grow. Although, just talking yesterday to Luther, he said that they don't seem to have any people coming by in any of the sites that they're going to. So we're trying to figure out what's behind that. The South Side, traditionally, I guess, a lot of it has been by phone calls for somebody to pick up their drugs, rather than an open drug market like happens more on the west side. So we don't know if that's transitioning to more of a low key kind of way of getting drugs or not. So we'll see. Because the last couple of days have been so warm, you would think there'd be a lot of people out. So I'll pause there. I know I'm kind of rambling, and there's a lot to talk about. There's a lot of, there's our schedule. We give this out every month, pretty much right before the end of each month, moving into the next one. If you are interested in joining, we do encourage people to come out and see what's going on. But we'd like to have you give us a couple, 3 days notice by calling Luther and letting them know, because we don't want to have more cooks than, too many cooks, I guess that's the word, and be off-putting to people who might want to come over there and talk with us. I was going to share this. I did mention it before. Here's the citywide EMS responses. You can see that in 2022, there were about 180 more EMS calls citywide. And you can see the different colors there. So 2021 is gray, 2022 is the light blue, and then you got the 2023 in dark colors. So dark blue. So we're following that. The Chicago Department of Public Health has a monthly meeting where they share this information to us. And they also, as I mentioned before, we used to get these heat maps that were about a year and a half old. These heat maps that were given are a month old. And they show, this is the West Side overview. You can see what percentage it is of the citywide total. We're 31% of the citywide total now. You can see trends month over month and year over year. And then they also highlight the hotspots on the west side where majority of the overdoses are happening. So you can see where the maps are. And then you can see the overdose responses by the community. And also what they do is break down each community. So we're able to see those overdoses in community and see the trends in there as well. And they're now doing that with the South Side as well. And we also, their GIS person, their geographical information systems person will actually send us emails like, hey, last night there were a whole bunch of EMS calls over at this spot. They had to give multiple doses of Narcan. And our team can go out and kind of check out what's happening out there, see if we can flood the area with Narcan. And, just let you know, the task force, you probably picked this up, but, usually when you talk about a task force, there's law enforcement involved in some kind of way, really kind of wipe this out. And that's not our approach. The Chicago police, especially the frontline people, are work with us very closely. Mainly worried being there to get trained periodically from us, get Narcan from us, and also to see if we're doing okay. But they're not using our location as a honeypot. So there's the Illinois Harm Reduction and Recovery Coalition. Carolyn, you want to talk a little bit about your role in that and our role in that?
Sure. Both Lee and I are members of the Illinois Harm Reduction and Recovery Coalition. So this is open to anybody who's providing any type of harm reduction or substance use services in Illinois. So this group has monthly meetings and is doing a lot of advocacy work. They have a new website that they've put together that has resources. It's actually a really nice website at illinoisharmreduction.org. And one of the things that the group is advocating for is, as Lee mentioned, overdose prevention sites, which are still something that we're trying to legalize in the state of Illinois. So this is something, if you are interested in being an advocate for this, you can sign a witness slip. I'm on the next slide going to give you a web address to do that right now. That this date that's shown on here, March 9th, is a little outdated, but it still is in this Health and Human Services Committee before it moves forward. I don't know, Lee, do you have any information on when it's going to be heard again in that committee? I know in March they never got to it.
Right. Well, it probably will not be going back to this committee, but it should be heard again at least before May. Quite frankly, what was happening from the state departments, et cetera, that would have been supportive of this is that we had a mayoral election that probably is going to be, very key to whether we're going to be able to do this. The HB2 basically directs the Illinois Department of Human Services to create the regulatory guidelines and the operational guidelines of what an overdose prevention site would be. And it would be creating a site on Chicago's west side. That kind of blunts some of the downstate and the Collier County knee-jerk reaction to what this would be. So, and we've done great research on this, and I can give you and Livy the connection to some of the done I mentioned before about our focus groups, etc. But I got a feeling it's going to pass this year. I think we've got, last time it was up was the last bill of the last day of the last session, for that year. And there were about maybe 10 or 12 not in attendance votes that we probably could have moved to a yes vote. So we were about 14, 15 short, and we believe we've got those votes. So Prevention Partnership and the task force will not be running an overdose prevention site. What we did was really kind of lay the groundwork and get the information from people and to people. And it'll probably be an organization that has a history of harm reduction work, but I'm not a mind reader or a crystal ball reader at this point.
So if you're interested in being a proponent and signing on in support, there's the link for that. And then just some other resources briefly to share. I don't know if people are aware that Narcan is available now at all Chicago public libraries. So you should be able to go in there and get Narcan at the library. If you also want to just find where Narcan is located near you, CDPH has a Narcan locator map, and that is a live link there where it says click here if you're interested in that. And then also, if you are a community provider, you can easily register with the Illinois Drug Overdose Prevention Program that will provide Narcan to you, and Illinois covers the cost. I know that this is how our program at AFC and CHH gets their Narcan to distribute, and it saves us a lot of money. And it's a wonderful thing that Illinois does. So it's very easy for community and healthcare providers to register online at that web address. And then you just put in your order for how many cases you want to have sent, and it happens really quickly and very easily. If you are interested in having fentanyl test strips sent to you, CDPH will also send out fentanyl test strips, and that web address is located up here, or the email to request fentanyl test strips. You can also request fentanyl test strips from Lee or me. This is a Never Use Alone hotline, which is just a great resource to provide to anybody who does tend to use alone, as much as we provide, tell people not to use it by themselves. Drug use is so highly stigmatized that people are full of shame and know that there's a lot of judgment out there and misinformation with the general public. And so people use by themselves. And so this is a way for someone to make a phone call to the Never Use Alone hotline, stay on the line with somebody. And typically the people who are the operators on this line are people in recovery or people who are current drug users. And they will stay on the line with you while you use, and they will call EMS if you don't respond within a certain amount of time. So it's completely anonymous, and you can go to this web address and print these out in like business card form to hand out. And then, of course, as Lee mentioned, Chicago Recovery Alliance is a wonderful resource for folks. They, at their web address, anypositivechange.org, they are out with this silver van on the west side and south side on a daily basis. They also do STI and STD testing, as well as handing out safer using equipment. And if you're interested in advocacy and policy on a national level, the National Harm Reduction Coalition is a wonderful resource just to learn in general more about harm reduction. Drug Policy Alliance does policy and advocacy in the US. They are also a wonderful resource. And then if you are interested in the meetings that Lee had mentioned with the West Side Heroin Opioid Task Force and the Chicago Department of Public Health, we have our monthly coordination meeting. So you could contact Sarah Richardson for an invite to one of those monthly meetings. And there is our contact information.
Well, I got to get a more joyful looking picture.
That's serious business, Lee.
I just give you an idea of the kind of cost savings for Narcan. I mean, 20 cases would cost $11,700. That would be 240 doses. So, people have asked, well, now that it's over the counter, is it going to be a panacea? There's going to be no panacea with over the counter Narcan. There's still enough stigma, so people probably are not going to go in there. And a lot of the people who need it probably are very uncomfortable going into pharmacies or into drugstores. So we're hopefully that'll save the state some money if we can use the over the counter version. And that's, we still need to have a distribution system to get it pushed out to the street and to anybody that needs it. As Rep. Ford said, it should be as ubiquitous as smoke detectors in homes.
Right. Yeah. So as Lee mentioned, the FDA just approved Narcan for over-the-counter sales, but a price point has not been determined yet. Of course, it should be free 99, right? Because if someone's running into a Walgreens to try to save someone from overdosing, they're not going to necessarily have any money, and it's a life-saving miraculous drug. So the price point is going to be key information. But like we said, getting it from the state of Illinois does save a lot of money. We used to get it at cost for $75 a kit, which, really adds up very quickly.
Yeah. Oh, thank you so much, Lee and Carolyn, for walking us through all of this. And now we have some time for questions or comments. You can put them in the chat or the Q&A, or I believe you could raise your hand and you could speak out your question. And I put in the chat 2 links. The first link I put is a link to our Mobile Action Center, where you can right from that link, contact your legislators to advocate for overdose prevention sites. And then I also put a link into an Instagram live talk that Carolyn and I did last August or September, which kind of goes over Narcan use and what it looks like while you're using Narcan. And I see that we have one question right now. How did the two of you get involved with this work?
You want me to go, Carolyn? I became a preventionist when I was 22 years old, had just graduated from college. Well, wait a minute, at 1972. And I started working at a St. Charles Boys School. And kids had been in there locked up. This is before the Juvenile Justice Act in 1973. And kids had been incarcerated since they were 9 and 10, 11 years old and were totally institutionalized. And I had a little voice in my head said, I got to get on the front end of this. And so I became a preventionist before I even knew that there was a concept of prevention. And then, I just also went to college in the late 60s, early 70s, and kind of realized that the hysteria around drug use was not helpful, and that we needed to have people out there with a very measured, non-stigmatic look at things. And especially when I came into Chicago to work with young people doing street on the Northwest Side with what is now Youth Outreach Services, we realized we could not be out there just telling kids not to use drugs, or we'd never be able to talk to them about what's really going on in their lives. And we also needed to be harm reductionists before that term was even there, kind of a ubiquitous. Ubiquitous twice in one day. That's pretty good. But we didn't want. We wanted to tell kids how not to die if they used it first. Now, how not to mix barbiturates with alcohol. How not to, use PCP in a way that could be very, very dangerous. Which most of the time it was. So that's how I became it. I just kind of kept following the trends and trying to make a difference. So, Carolyn.
I worked in traditional inpatient treatment for several years on a men's unit for mandated males, and really was witness to how traditional treatment didn't work for a lot of people. It was at the place where I worked, a very punitive system, and I saw a lot of people get kicked out of treatment for exhibiting the symptoms for the very reason that they were there. And then end up overdosing when they left because they had, no opioids in their system, and they were very at high risk for overdose. And so that's what brought me to harm reduction, when I realized that traditional abstinence doesn't work for everybody, and to gain an understanding that people use drugs and will always use drugs regardless of criminalization, regardless of prohibition. It is just a fact that is what people do. We all want to, enhance our joy or mitigate our pain, whether that pain is emotional or physical. People have a right to do that. And so that's what brought me to harm reduction, because harm reduction really is just unconditional love and accepting people for wherever they're at. And oftentimes that is the path for people to feel better about themselves.
Awesome, thank you. We have another question I see. Where did the term harm reduction come from?
I'm not sure. I mean, I think it's kind of associated with the AIDS epidemic, and when needle exchanges occurred, et cetera. But it also, I think, was just to say, hey, if we're just always pushing for abstinence, we're not going to be dealing, you're going to be cutting out a whole group of people that, like Carolyn said, for various reasons, want to use. And so we had to have measures to say, well, look, like I said before about the young people, we don't want you to die the first time you try something. We want you to know what dangers are. We want to, of different ways of using, the dangers of mixing drugs, et cetera. And it shouldn't be forbidden to tell people that. I remember there's a book, it's probably still in in publication. It's probably been revised times, called Chocolate to Morphine, and Andrew Weil. And there's a book that kind of basically covered all the drugs and told you about what happened, the history of them, and then how not to use, how to use them safely. And I remember someone from a parent group that I was tabling across from telling me that they hated that book because it told people how to use drugs. And, I said, well, it tells them how to not die using drugs. So, but hey, whoever wants to use it, as long as they're dealing with the tenets of it. And as Carolyn said, but also we need to design our programs with input from people who can tell us about whether those programs meet their needs and why they do or why they don't meet their needs.
Yeah, thank you. I'm gonna go to Jonathan Keeney, who I think has a question. I'm going to unmute you if you would like to speak your question.
Okay, yeah, thank you. Yeah, my question is, while we are still living in a time of like prohibition, if you could speak more about the Good Samaritan law that I believe is a state law. I'm just as someone who educates people like who use drugs about like, overdose prevention and things like that. I just don't know if that law is upheld and like if people call emergency services after an overdose or something like that, are they still at risk for being arrested and things like that if they have drugs on them? Like how to better educate people, in the work I do.
Yeah, they're not supposed to arrest you for, calling and being there and accompanying a person when they show up. I think that was just expanded. I should know this better, that to really include probation and parole. The main thing, there, Jonathan, and everybody, is really, we don't want people just to abandon someone because they're afraid of getting arrested. There's a surge in some areas that use that overdose call for for a drug-induced homicide. I haven't heard of that happening much in Chicago at this point. It might happen somewhere downstate. Carolyn, do you have any idea or anything to add to that?
No, the only thing I wanted to say, I mean, every state has Good Samaritan laws that protect you from stepping in good faith to intervene in a medical emergency. I don't know in all cases what police might do. I always encourage people, if they do call 911, if they are witness to an overdose, police don't need to be involved in overdoses. And so to tell the 911 operator that someone is having a breathing emergency rather than specifically stating there is an overdose or potential overdose involved, because that will bring the police there. But those Good Samaritan laws should protect somebody. But I don't know that it's 100% foolproof, depending on who you are, to the person that's using, depending on your background with law enforcement. But generally, those laws should protect everybody. And that just goes to emphasize the issue with criminalization is people are scared to call law enforcement. And so they run, and that person who's overdosing is then left by themselves.
And I've had no reports of our outreach team who have either saved a life or been around that, where there's been an issue with the police about that. We still are trying to work out what the rules of engagement are sometimes with the EMS people. And we also are really trying to go upstream, because we've had a situation where somebody who had the 911 operator, and the operator said, don't give them Narcan until the EMS people arrive, and that led to a death. So we're finding that script for that, and we need to get that fixed. That's one of the things we found out that we really need to get fixed ASAP, so that every 911 has a script that they can follow that gives the correct information.
Thank you. We have time for one more question, and I see it in the Q&A. And it's, can you discuss a bit more about the initiative for training CTA staff on Narcan administration?
Right, well, we're still trying to get the right CTA folks together to really talk about what the barriers are. That may, we may end up not getting to train them. They have unions, they have all sorts of other kind of rules and regulations, although, like as Jonathan said, there's a Good Samaritan law. But we do also have some provider service, like night ministry and excuse me, Heartland, help me, Carolyn. Just space it up. Anyway, there's a couple organizations that are on the trains that are giving out Narcan and may be available when that happens. The Haymarket Center, I'm sorry, I work with him. So, but anyway, so we're still in the kind of the infant stage, but our three co-chairs, two of them are from Haas, Healthcare Alternative Systems, and I mentioned Sheila Haneke, the mother. They're getting some press out on this, so I think we're going to be moving the needle. Hopefully, with the new mayor, we can kind of get that and say, "Hey, we've been here longer. This is what's happening. So join us."
I think it's also helpful that our new mayor has shared about his personal story with family members who have struggled with addiction.
Right.
Yeah. Well, thank you so much. And then thank you all for attending and participating. Look out for an email with the recording and the PowerPoint, along with all of the resources and links that Lee and Carolyn shared with you today. Thank you.
Thanks, Livy. Thanks, Lee.
Thank you, Carolyn. Thank you, Livy.